Hey everyone, I'm sorry I can't be with you in person, but I am really excited to have the opportunity to chat with you about depression management in primary care. So I think now that you're a week or so into immersion, I bet that many of you have seen some patients with depression. I think this is a really major part of what we do in primary care, especially now during a pandemic, social unrest, and then in the internal medicine population who are burdened with many chronic health conditions. Depression management is something that I've really come to love and find a lot of meaning in my visits. And so I hope that I'll be able to give you some tools today to have an approach to depression and feel empowered to treat this important problem. So just a roadmap of what we're going to be talking about today. A general approach to depression in clinic I want to give you. We'll talk about screening and diagnosis of depression. We'll talk about kind of the history, physical, and labs that we get to rule out other etiologies of mood disorders. We'll talk about some treatment options, medicine side effects, what we do with refractory depression, and then we will have time to talk briefly about suicide risk assessment and then some in-office counseling strategies. So here is my general approach to depression and the routine cases that we see in clinic. In general, we screen with the PHQ-2. So in patients who are asymptomatic, who are coming in for a wellness visit, in our clinic, the policy is that we screen with a PHQ-2. The USPSTF says screen if you have the ability to treat. All of our clinics have the ability to treat depression, so all new patients should be having this done. And so a screening PHQ-2 looks like this. It's the first two questions of the PHQ-9, and it's asking over the past 2 weeks, how often have you been bothered by any of the following problems? Little interest or pleasure in doing things, or feeling down, depressed, or hopeless. Anyone who answers more than 1 point should receive a PHQ-9, and a positive screen is technically 3 or more. Okay, so next up is the diagnostic PHQ-9. And so screening and diagnostic are different, right? So if you have a patient on your schedule that you're concerned for depression, where the chief complaint says something about low mood or feeling tired, you can feel empowered to ask your medical assistants to give the patient a PHQ-9 form to work on before you come in the room. And so the PHQ-9 form is what either a positive screening PHQ-2 will lead to, or if you're concerned and you want the patient to do a diagnostic PHQ-9. And it looks like this. You can see the questions kind of ask about a variety of depressive symptoms, and then ask the patient to grade whether this is bothering them not at all to nearly every day. You'll add up these points and give a score. And then at the bottom, it's asking patients a couple of really important questions. Number one is thought that you would be better off dead or hurting yourself in some way. That's the last numeric question. And I would just encourage you when you're looking at a PHQ-9 to have an approach to first kind of take a peek at, okay, generally how severe is their depression? What are the most bothersome symptoms? Then always look at this question, thoughts that you'd be better off dead or hurting yourself in some way, because that means that you need to address that in that visit. And then finally, looking at how difficult does the patient grade these symptoms? Are they answering only several days, but extremely difficult function, versus are they having symptoms nearly every day, but it's only not at all difficult or somewhat difficult for them to function? So that would be an approach to interpreting your PHQ-9. Okay. The next step, once you have a diagnostic PHQ-9 completed, then you're going to be thinking about the history, exam, and labs that you want to be doing in clinic. And this is to evaluate for concurrent problems and to rule out other etiologies. And so I'll just pop these DSM-5 criteria up. So it's in addition to having 2 weeks of at least 5 of the PHQ-9 symptoms, you need to have clinical distress, and then you also need to not have these be attributable to a medical problem, a drug, or another psychiatric condition. So important in our history exam and labs to be ruling these other things out. So next up, we'll determine the severity. This is based on the PHQ-9 and how it's impacting their lifestyle. And then we'll start treatment, medication or counseling based on how severe their symptoms are and the patient preference. And then the next step in our roadmap is just having close follow-up, where we troubleshoot side effects of medicine, deal with refractory symptoms, and then decide when to stop treatment. So I'll just point out that in our depression roadmap, steps 1 through 5 can be done in the first clinic visit. So it's good to have an approach here, and that's what our goal will be, going through a couple cases. So starting with our first case, this is Miss Logan, who has fatigue and low mood. So you see her on your schedule, and you take a peek at her chart before she comes in, and you gather that she's 55 years old, has a history of Hashimoto's thyroiditis, on thyroid medication, last seen for a wellness visit a few years ago, no chronic medical problems, no documented social or family history. Her meds just include thyroid medicine, some vitamin D, and melatonin if needed. So because you saw that she had fatigue and low mood as her chief complaint, you asked your medical assistant to give her a PHQ-9 before you went in the room. And this is what you see. You see a lot of symptoms that are bothering her more than half the days. And then nearly every day she's feeling tired or having little energy. Then kind of scanning down to thoughts that you'd be better off dead or hurting yourself in some way, she answers not at all. Looking at how she grades the difficulty, she grades her symptoms as very difficult. And so when we add up her PHQ-9 score, she has she falls in the moderately severe range between 15 and 19 points. So I think now all of this has happened before you go in the room, right? And I think before you enter the room to see Ms. Logan and talk to her about her symptoms, it's important to think about how we set the tone for our patients when they're seeking treatment for depression or other types of mental health care. I don't know how many of you yourselves, your friends, your family members have sought mental health care. For some people, this is no big deal. They think of this as not a stressful thing to talk about. Other people are terrified to talk about this. The other day, I had a patient who had been nervous to reach out to talk to a healthcare provider for 2 years about her anxiety and depression. And so I think it's important to remember that this can be a really, really big deal for a patient to be bringing these concerns to you. So a couple of phrases that I have found to be helpful are, I'm so glad that you came in to talk about this. I know it can be hard. Another thing that I'll say sometimes is, I hope you're really proud of yourself for seeking help for this. I know it can be hard to do. And then the other thing that I think is important when people are coming in with depression is to normalize and say, this is a really common problem that we see in primary care, and I can help you feel better. So anyway, just important to remember, because this does become pretty bread and butter to us. So when we walk in the room, I want us to kind of have an approach to gathering a history for Miss Logan. So my approach to a depression history is pretty broad, just asking about what are their most bothersome symptoms, what are their stressors, how's their support system, what are their hopes and goals around treatment. So for Miss Logan, she's having fatigue, no energy, not really feeling happy, nothing feels fun, but most bothersome to her is their lack of energy. Her current stressors are that her cat's getting sick, her daughter left for college, working from home during the pandemic is really hard. She has good social support in her husband, and then her best friend has depression and recommended that she see a doctor for her symptoms. Then her hopes and goals for treatment are that she wants to feel better and she's willing to do whatever it takes. I think it's really important to inquire about what people's hopes and goals are, because it really can elicit what they've thought about already. People often have thought about whether they would be willing to take medication, whether they would be willing to see a counselor. Okay, so we've gotten some information from Ms. Logan. Here's the other data that we need to gather. in our history, on our exam, and our labs. And this is kind of the section I always think of the DSM-5 criteria, where I'm thinking about this is how we find out that this is not better explained by another psychiatric disorder, this is not better explained by another medical disorder, and this isn't better explained by a medication that they're taking. So in their history, you want to ask about psychiatric history, whether they've had manic or hypomanic symptoms, whether they have any psychotic symptoms, substances, and medicines, right? On their exam, really different providers kind of have different approaches here, but I think it's reasonable to be feeling their thyroid, to be kind of looking for common signs of anemia. And then I just tossed adrenal insufficiency on here because I think that'd be pretty cool to see, like that hyperpigmentation or something, but I think that'd be pretty uncommon, but easy to look, I guess. And then thinking about labs. So I would say that most providers will get a TSH and a CBC to rule out thyroid disease and anemia. Getting other labs like electrolytes, nutritional labs, adrenal labs are really going to be more based on your history. Okay, so we've gathered all this data. And then I want us to think about what's our approach to treatment here. And so I'll frame this as this is a patient-centered discussion. You obviously can't make someone take a medicine or you can't make someone do counseling if they don't want to. But when people ask your advice and opinion, this is kind of the recommendations that you should be giving. For someone who has mild depression with a score of 5 to 9, they benefit equally from medication or counseling. When you move into the moderate range and the severe range, really people should be starting to take a medication. In the moderate range and the severe range, counseling can add benefit, but the medication is really where you're going to get your most bang for your buck. And then I'll just say combined therapy doesn't show a short-term benefit, but adding psychotherapy in can help protect against relapse for people. So again, this is just to frame your recommendation. Oftentimes people need some time to think about options. Some feel more comfortable with a medicine, some feel more comfortable with counseling. All are reasonable. So let's jump to counseling quickly, and then we can talk about medicine. But counseling is really important and especially useful for people who want it, right? It is good for people who have good insight into their condition, and it's really good for people who are interested in learning coping skills, but obviously not something you can force on someone. There's a couple different types of evidence-based counseling, and I would recommend that you ask your social worker for a list of providers that might be available to your patients. You can also direct your patients to a website called Psychology Today, where they can enter their insurance and their location and find some counselors that might be available to them. There are a couple types of evidence-based counseling, including cognitive behavioral therapy, interpersonal therapy, and problem-solving therapy. The most common one that I see is cognitive behavioral therapy, and this is really this idea that you can identify and modify dysfunctional thoughts. And so it's focused on teaching people how their thoughts and their emotions and their behaviors and their moods all tie together. And then you can start intervening on each to yield more positive emotions, positive behaviors, things like that. So the interpersonal therapy, problem-solving therapy are less common. Interpersonal therapy focuses a lot on kind of like what are the roles that you're playing, what might be contributing to your depression, and then problem-solving therapy is just kind of focusing on coping skills. I will just point out here that talk therapy is not on here, right? That's not an evidence-based approach. Really, cognitive behavioral therapy and these other types are focused on coping skills and behavioral change, which I think is very important. Okay. Transitioning to medications, I want to give you some ideas about what first-line agents are. So first-line agents include the SSRIs, the SNRIs, bupropion, and mirtazapine. We don't often use things like the tricyclics or the MAOIs due to side effects. So let's jump into talking kind of about the SSRIs first. And I'm including brand names here just because it's really common that people talk about antidepressants by the brand name. And so I want to try to generate some memory for you here, because I still have to Google this sometimes trying to remember which drug is which. The SSRIs kind of come on a spectrum from sedating to activating. And my recommendation would be to just choose a couple that you're comfortable with. I think kind of choosing some in that more neutral range are important. So I've put stars on sertraline and escitalopram. Citalopram can also be included here. There just wasn't room on the slide, but it's also in that kind of neutral category. So thinking about the spectrum of activation, starting with the sedating side, we have paroxetine or Paxil. This medicine, I don't think you're ever going to be initiating in people, but sometimes people will come to you on it. It has pretty intense side effects with weight gain, sexual side effects. It also can cause withdrawal. So don't use this medicine. The more neutral ones are sertraline or Zoloft and escitalopram or Lexapro, as well as citalopram. In my anecdotal experience, sertraline works well in young people, but it does cause a little more diarrhea and GI upset. Whereas escitalopram has been shown in meta-analyses to really be the best SSRI in the primary care setting. So it has the fewest SSRI side effects and fewer drug interactions. Yeah, and it's honestly, my patients on this medicine tend to do really well also. And then finally, an activating option is fluoxetine or Prozac. This has a really long half-life, but it is kind of activating. You can use that to your benefit, right? If somebody's just really, really anhedonic, sometimes this can help, but it can also make people feel jittery. So this is kind of where I would start with the SSRIs. I included the dose ranges there, but you can always look it up to date. You start at a low dose, you tell them to start that for 6 weeks and then check in and then increase the dose if they're having a partial response to it. I think important before you start an SSRI to just think about what the sexual side effects are, what the GI side effects are, because people really are bothered by these. It takes 6 to 8 weeks for an SSRI to kick in, and the sexual side effects and the GI side effects kick in right away. And so giving them anticipatory guidance that yes, you're going to have some GI upset, that will go away on its own within the first several weeks. The sexual side effects can vary from person to person, but are more chronic with this medicine. And then that the mood effects will kick in sometime in that 6 to 8 week range. Okay. So if somebody says, I cannot take a medicine that has those side effects, I'm not willing to do that, then think about other medications that might be available to them. And so again, these other non-SSRI medicines fall on a spectrum from kind of more sedating to more activating. And so I'll say that you should be familiar with mirtazapine, venlafaxine, or duloxetine, the SNRIs, and then bupropion or Wellbutrin. I think all of these are good. The ones that you probably will be most likely to use in clinic and that I would recommend really learning are the one SNRI, take your pick, and then Wellbutrin. So thinking about mirtazapine first, you can use its side effects that to your advantage. So it oftentimes increases people's appetite and can promote weight gain. It also can help people who have trouble sleeping because it's sedating. The SNRIs, like venlafaxine or duloxetine, are also approved for management of neuropathic pain and anxiety, but they do have these withdrawal effects and seemed, in my experience, to have slightly more side effects as people are starting them, whether that's like headache or GI upset. But some people, this is a really great option. So think about what the other comorbidities are that your patient has. And if they have neuropathy, think about this as a first line. And then Wellbutrin. This is an awesome medicine. My patients really like it. I think that's been the experience of many of us. So this is a great one to have in your back pocket, or maybe even your front pocket. So Wellbutrin doesn't have the sexual side effects. It improves vegetative symptoms, and it kind of gives people energy. You can't use it in people who are at risk for seizures, so like folks with eating disorders or people with a history of epilepsy, and then it can also really worsen anxiety. So think about this in folks who are coming in with really primary depressive symptoms, the anhedonia and fatigue. Okay, so I think those are, that's a couple SSRIs to know, an SNRI and Wellbutrin. Okay. So let's get back to Ms. Logan. Thinking about what labs we should check. We got a TSH and CBC. Those were normal. And we decided that we would start an SSRI. Okay. I already told you that escitalopram and sertraline are my go-tos. And so we start for her escitalopram, 10 milligrams daily. When she comes back in 6 weeks, her PHQ-9 has decreased from 16 to 9. And her most improvement has been in her feeling hopeless, but she's still having a lot of low energy and poor concentration. So what's our next step? Our teaching point here is that if a medicine is working and is tolerated and isn't at a maximum dose, increase the dose. So she's responding to a low dose of escitalopram, so let's increase it and have her follow up with us. So a couple weeks later, she comes in taking escitalopram 20 milligrams daily. Her PHQ-9 has decreased from 9 to 4. Motivation's feeling better, and she wants to know, hey, when can I stop taking this medicine? So first question is, how do we define remission of depression? And that is just having a PHQ-9 score of less than 5. And patients should really be feeling like their depressive symptoms have gone away. And then when can we stop treatment? Well, here's a table for us. And this, again, is a very patient-centered approach. You can't force someone to stay on a medicine that they don't want to stay on. And you don't have to stop a medicine in somebody who feels like they're deriving benefit from it. But if someone asks for your recommendation for a first episode of depression, oftentimes people will be treated for a total of 9 to 12 months. For a first recurrence, they'll also be treated for 9 to 12 months. And if there are any additional recurrences, then it's reasonable to recommend lifelong treatment or more chronic treatment, just kind of based on patient preference. Okay, so teaching points from our case about Miss Logan. I think number one, really acknowledge when patients are seeking mental health care. It becomes bread and butter routine to us, but I think it's really important to validate their seeking help and make them feel comfortable to kind of sharing in a vulnerable, often stigmatized topic. Choose your initial treatment strategy based on the severity of symptoms that the patient is having and what they're preferring. So this is how you choose between counseling and medicine. Medicine and counseling are equally effective in mild symptoms, but once you get into that more moderate and severe zone, you should be recommending that people start a medicine. We talked about our first line agents being SSRIs, SNRIs, bupropion, and mirtazapine. And we talked about how we counsel some side effects and then do close follow-up. And then when a patient is experiencing benefit but is not in remission, then the first step is to increase the dose of that medicine. And then as far as duration of treatment goes, really around 9 to 12 months for that first episode, though this is guided by patient preference. Okay. We're going to move on to our second case. And this is our next patient for the afternoon. This is Mr. Jordan, who's here for a low mood. So you are chart reviewing him. You already know, because it says low mood, that you're going to ask your medical assistant to give him a PHQ-9 before he comes in the room, or before you enter the room. And you pre-chart on him and find that he's 48 years old, has a history of depression on chronic sertraline, type 2 diabetes on metformin with an A1C of 6.7, hyperlipidemia, and he was last seen for diabetes follow-up about 6 months ago, and you don't see that mood was addressed at that visit at all. His medicines include atorvastatin, metformin, and sertraline 50 milligrams daily. So sertraline 50 is a pretty low dose. Okay, so you get your PHQ-9 and you see this before you walk in the room. So wow, we're seeing a lot that's in that nearly everyday column. And then, oh boy, here we go, the thoughts that you'd be better off dead or hurting yourself in some way. We see that he's having those thoughts several days per week. And then he's rating his difficulty as extremely difficult. And so he's falling into that severe category of depression. So what is our first step when we see a PHQ-9 like that? The first thing that comes on my list is to make sure that we're assessing our patient's safety. I think it's really concerning when someone's having thoughts of self-harm, and I want to empower you to go in and do a safety assessment. And so suicide risk assessments, I think, are really hard, and I want you to feel comfortable asking for help. And that's definitely what I did for the first 2 years of residency. And honestly still sometimes ask for help from our social work team or other attendings in clinic. So the risk assessment is based around kind of finding out the frequency and intensity of the thoughts of self-harm. You need to find out whether someone has plan or intent, whether they have access to lethal means. We all know that prior attempts at self-harm or suicide are the biggest predictors for future attempts. So important to ask about that. Finding out about their support system and social situation is important. And then you can kind of dive more into those risk factors and protective factors. Risk factors include kind of previous suicide attempts, history of mental health disorders, substance use, kind of impulsive tendencies, feeling isolated, having a lot of chronic medical problems, having easy access to lethal means. I could go on, but kind of important to ask after those things. And then also making sure that you're talking to people about what are their protective factors. So people who have strong family and community support are less likely to harm themselves. People who have skills in problem solving and conflict resolution, people who have cultural or religious beliefs that discourage suicide, are all kind of some protective factors. Okay, so you've done your risk assessment, then you're moving on to safety planning. And this is some language that I use. Is our first priority is keeping you safe. Let's work together to develop a plan for when you're having thoughts of suicide. And this is where you can ask them to come up with a plan with you. So who would they contact? How would they distract themselves? Can they go home and remove their access to lethal means if they have a plan and they've gone and purchased supplies, things like that. And then it's really important here to ask, do you think you need help to keep yourself safe right now? Because if they do, then sending them home is not an option. And so that brings us to our disposition. People who are having thoughts of suicide with active intent and active plan are not appropriate to be sent home. They need emergency evaluation. Other folks, maybe just are really high risk but don't have active intent, then you want to get them an expedited assessment with a mental health provider, evaluate evaluating them. Other folks, maybe it's more a chronic problem. They're not worried about it. They just said it's something they've been dealing with for a long time. Important to have them follow up with a mental health provider. And then other folks may be appropriate for you to follow up with in the next week or so. Okay, this is really hard. And so please ask for help. I don't want anyone feeling like they're making these decisions alone, because it's often, it falls into a gray area and you have to be trusting what the patient is telling you, which can be really hard. Also, here's the suicide helpline and also this crisis text line at the bottom of the screen. And those are resources that you can give your patients as part of their safety plan. Okay, getting back to Mr. Jordan. So what can we offer at this visit? We can assess his safety, we can increase his sertraline, we can refer him to counseling, we can do some labs, and we can see him back closely. And so when we do our safety assessment, he tells us that, oh, you know, I have thoughts of hurting myself, or just that I'd be better off dead, maybe twice a week. They're pretty fleeting, they're not intense. I don't think I have a plan. Sometimes I'll think about like jumping off a bridge if I'm walking by one, but it's more just a fleeting thought. I don't think I would ever do it. Okay. So you decide that, okay, that's concerning. We need to follow up closely. He's going to establish with a counselor. We don't need to do any sort of emergency evaluation at this point. So you see him 6 weeks later, and he's established with a counselor he really likes, not having thoughts of self-harm. You've bumped up his sertraline to 150 milligrams daily, and he's tolerating it well, but he's still feeling really crummy. He's depressed, has low energy, low motivation, anhedonia, he's sleeping all the time, and his PHQ-9 is now 15 from 20. So it's going down, but it's really not going down a whole lot. And we're definitely far from remission with that PHQ of less than 5. So this is what I would call a failure of his first line medicine. The sertraline is not helping. So the question becomes, what do we do when our first line's failing? Do we switch within the class? Do we switch between classes? Or do we augment by adding a medicine? So I don't know if any of you had to read the STAR*D trial as part of your psychiatry rotations in medical school, but essentially it's a trial that's looking at how do we manage depression that's unresponsive to initial treatment. So a bunch of patients were treated for 12 weeks with citalopram, patients with depression, and 70% of them had some response, but only 30% went into remission. So they took those folks who had some response, like our patient, and either switched them to an alternative agent, like a different SSRI, an SNRI, or bupropion. And they, about a quarter of them achieved remission there. Then they took the same patient population, and instead of switching to a different medicine, they just augmented, meaning added bupropion to some patients. And about a third of those patients achieved remission. So really what this all boils down to is that psychiatrists and people in primary care have kind of interpreted this to say, 25%, 30%, that's pretty darn close. It seems like it's a reasonable approach to either switch to an alternative agent or augment with another medicine if your first line agent is failing. So totally okay to do either, and appropriate to talk with your patient about what they would prefer. So options for augmentation come back to some of these more familiar medicines. So again, we'll talk about mirtazapine as an option, some antipsychotics that can be used, and then our good old Wellbutrin. So mirtazapine can be a helpful augmenting option when people are having very little appetite or trouble sleeping. This can help them with those symptoms. If people are having some psychotic symptoms with their depression or just can't tolerate other medicines, you can try using something like quetiapine, Seroquel, or aripiprazole, which is Abilify, I think. And these ones are really a little tough because they come with that weight gain side effect and all those metabolic derangements and metabolic syndrome. So less likely to be using these. And then we've got Wellbutrin, which honestly is a great medicine to add to your SSRIs, especially in folks who are having sexual side effects, because it can help those side effects. It can also help augment and improve their mood symptoms. But again, you can't use them in somebody who has seizures or who has bad anxiety. Okay, so those are our options to add. And so going back to Mr. Jordan, we're going to use some Wellbutrin on him. And he comes back in 6 weeks. He's feeling way better. His PHQ-9 is now 5. And he wants to kind of keep things the same for right now. He feels like he's making good progress in counseling, and he's working on some CBT and behavioral activation. So what is behavioral activation? This is something that you can do in clinic, and it's kind of an in-office counseling strategy that I would love to empower you with. So if patients are interested, this is a really cool thing that you can do. It's super simple, and so kind of feels silly to even say, but I think it's actually has a lot of power in people's lives. So what I think it boils down to is do the things that will make you feel better, even if you don't feel like doing them. And when I say it that way to patients, it kind of feels like a light bulb goes off in about half of them, where they have just been feeling so guilty that they don't have the motivation to do things that make them feel good, like going for a walk or brushing their teeth, that they feel like they shouldn't do those things because they don't have motivation to do them. And I say, put an alert in your phone that tells you to brush your teeth every day and just do it even though you don't want to. And they're like, oh, okay, I guess I could do that. So liberating them to do things without motivation is kind of helpful. So this can be things like physical activity, hygiene habits, just getting out of bed, but it's identifying something in the patient's life that makes them feel better that they're not doing. So like brushing your teeth or exercising, and saying, okay, let's figure out what the barriers are to you doing this, and how do we get you to make a small change to start doing this thing again. And so you take concrete steps to reintroduce this activity into the patient's life. It kind of decreases their avoidance behaviors, improves their mood, and then kind of creates a positive spiral upward. Okay, so that's pretty simple. I do think it's really effective, especially as you're kind of bridging people to a long-term counselor. I tell everyone to try to go outside, but sometimes just brushing your teeth is a good place to start. Okay. So that's a lot of what I had to say about depression management. I think it's important to think about, when do we refer to psychiatry? And this is a nuanced question. Obviously, there's a lot of gray area here, but I think it's totally reasonable to be referring people when you have diagnostic uncertainty, if they have a whole bunch of comorbid psychiatric conditions, if you think they're at high risk for suicide, if they're not responding to your initial attempts at treatment, if they have really treatment-resistant depression. I think that that's really appropriate to ask for the expertise of the psychiatrist. Okay. So teaching points from our case about Mr. Jordan. I think it's really important to ask about suicidal thoughts when we're discussing depression, and being ready to perform a suicide risk assessment that's focused on what's the frequency and intensity of the thoughts. Is there a plan? Is there intent? And then all those other components that we had talked about. And then thinking about a safety plan. Who would you reach out to if you thought about hurting yourself? How would you distract yourself? How can we make sure that you don't have access to lethal means? And empowering people with the suicide hotline and the crisis text line. And then let's see, when depression's not responding well to an initial first-line agent, according to the STAR*D trial, it's reasonable to switch agents or to augment with a different medicine. And Wellbutrin, mirtazapine, and the antipsychotics are appropriate augmenting agents. And then finally, if you have the right patient, if you have the time and interest in clinic, you can try using behavioral activation as a strategy that's evidence-based in primary care to help people in their depressive symptoms. So finally, some resources here. The Annals of Internal Medicine has an awesome series called In the Clinic, where they talk about common outpatient problems. They have them on dyslipidemia, hypertension, hyperlipidemia, oops, I already said that one, but diabetes, things like that. And they also have one on depression that I think Marianne and Whitney have linked to this talk. Okay. And then finally, the Curbsiders podcast. Not sure if that's something that you like listening to, but I think it can be really helpful. Episode number 35 is about depression in primary care. And then episode 140 is about antidepressant medication management with a psychiatrist on the podcast. So I thought that was pretty helpful. Thank you for bearing with a faceless Zoom presentation. And I really hope this is helpful. I think depression is super important to feel comfortable managing in primary care. And I hope that these skills will serve you well and serve your patients well. Depression is cool because you see people back frequently and you see them get better. And so I wish you many satisfying cases of depression management. Okay, thanks everybody.